This is a recap of Chapter 7 of the PMHNP Review and Resource Manual about pharmacology. I'm going to just address or review the titles that are listed in this chapter and without adding anything else, and will likely make a second video breaking down individual drugs. Psychopharmacology is one of the most active and developing areas of psychiatric research. It is the use of psychotropic medication to treat psychiatric disorders. Psychiatric mental health nurse practitioners must have a thorough understanding of the science and art of prescribing, of the pharmacokinetic and pharmacodynamic actions of a given drug, as well as the client's motivation to take the drug. The basic pharmacological principles are discussed in this chapter. Pharmacokinetics is what the body does to the drug. I'll repeat that. Pharmacokinetics is what the body does to the drug. Absorption, distribution, metabolism, and first-pass metabolism. Absorption is the method and rate at which drugs leave the site of administration. With oral medication, absorption normally occurs in the small intestine and in the liver. Distribution occurs after the drug leaves the systemic circulation and enters the interstitium and cells. Drugs are redistributed in organs according to their fat and protein content. Most psychotropic medications are lipophilic and highly protein-bound. Only the unbound free portion of the drug is active. Therefore, people with low protein albumin levels, such as with malnutrition, wasting, or aging, can potentially experience toxicity from an increased amount of the free drug. People with high fat to lean body mass ratio, such as in older adults, will have erratic amounts of the drug in their system. Metabolism and elimination. Metabolism is a process by which the drug becomes chemically altered in the body. First-pass metabolism is a process by which the drug is metabolized by cytochrome P450 or the P450 enzymes in the intestines and liver prior to going into the systemic circulation. Elimination is the process by which the drug is removed from the body. Half-life is the time needed to clear 50% of the drug from the plasma. The half-life also determines the dosing interval and the length of time to reach a steady state. A steady state is a point at which the amount of drug eliminated between doses is approximately equal to the dose administered. Drugs usually are administered once every half-life to achieve a steady state. It takes approximately 5 half-lives to achieve a steady state and 5 half-lives to completely eliminate a drug. Alterations in pharmacokinetics. Hepatic cytochrome P450 enzyme interactions can induce or inhibit the metabolism of certain drugs, thus changing their desired concentration levels. Approximately 10% of Caucasians are poor metabolizers of the P450 2D6 enzyme, and approximately 20% of Asians have reduced activity of the P450 2C19 enzyme. Cytochrome P450 enzymes. I remember these as 1, 2, 3. And basically I just put them in order. There's 1, A2, then there's 3 2s, and there's obviously 1, 3. And these are the ones we're most concerned about with psychiatry and medication. And just to remember them, not necessarily link them to anything, but just to remember them, I just think 1, 2, 3. That's 1A2, 2C9, 2C19, 2D6, and 3A4. First-pass metabolism activity of the P450 enzymes in young children may exceed rates of adolescents and adults and give rise to underexposure to certain medications. Conversely, the 1A2 pathway is delayed, possibly leading to a toxic effect from drugs that are substrates of this pathway, for example, some antipsychotics. CYP450 inducers and inhibitors. Enzyme inducers can decrease the serum level of other drugs that are substrates of that enzyme, thus possibly causing subtherapeutic drug levels. Enzyme inhibitors can increase the serum level of other drugs that are substrates of that enzyme, thus possibly causing toxic levels. The way I remember inducers and inhibitors is that inhibitors keep the drug in, causing the drug levels to rise within the body. And inducers, I see them as induce or push out faster. So I think of an open door and being pushed out. And so if you're pushing out the drug faster, then what's going to be left in the body are lower drug levels. And that's how I remember that. Liver disease will affect liver enzyme activity and first-pass metabolism, possibly resulting in toxic plasma drug levels. Kidney disease or drugs that reduce renal clearance, such as nonsteroidal anti-inflammatory drugs, may increase serum concentrations of drugs that are excreted by the kidneys, for example, lithium. So NSAIDs can increase lithium levels. NSAIDs can increase serum concentrations of lithium. Older adults are more sensitive to psychotropics because of their decreased intracellular water, decreased protein binding, low muscle mass, decreased metabolism, and increased body fat concentration. Pharmacodynamics, what the drug does to the body. I've bolded the D in pharmacodynamics and the D in the word drugs because that's how I remember pharmacodynamics is what the drug does to the body. Target sites for drug actions include receptors. Several types of pharmacodynamics involve receptors. Agonist effect is the drug binds to the receptor and activates a biological response. Inverse agonist effect is the drug causes the opposite effect of the agonist. It binds to the same receptor. Partial agonist effect is it does not fully activate the receptor. That's why I have the picture. The first picture shows a partially lit room, which is often used to talk about the effects of partial agonism. So the drug does not fully activate the receptors, not fully. And then antagonist effect is the drug binds to the receptor but does not activate a biological response. Another site for drug actions is the ion channels, which exist for many ions such as sodium, potassium, chloride, and calcium, and can be open at some times and closed at other times. Neurotransmitters or drugs may be excitatory or inhibitory depending on the type of ion channel they gate. Excitatory response is depolarization. It involves opening of the sodium and calcium channels so that these ions go into the cell. An inhibitory response is the repolarization phase, and it involves the opening of chloride channels so that chloride goes into the cell and potassium leaves, or both. I'm going to repeat this. So excitatory response is depolarization. It involves the opening of sodium and calcium so that these ions go into the cell, sodium and calcium into the cell for depolarization. An inhibitory response is repolarization, involves the opening of chloride channels so that chloride goes into the cell. So during repolarization, which is an inhibitory response, chloride channels go into the cell and potassium leaves the cell. Another site for drug actions are enzymes, which are important for drug metabolism and play an important role in the chemical alteration of the drug. Some drugs, such as the monoamine oxidase inhibitors or MAOIs, inhibit the action of a particular enzyme, thus increasing the availability of the neurotransmitter. Another site for drug actions is carrier proteins or reuptake pumps, which transport neurotransmitters out of the synapse and back into the presynaptic neuron to be recycled or reused. Some drugs, such as selective serotonin reuptake inhibitors or SSRIs, will inhibit the reuptake pumps, thus increasing the synaptic availability of the neurotransmitter. Other terminology. Potency. Potency refers to the relative dose required to achieve certain effects. Tolerance is the process of becoming less responsive to a particular drug over time. Tachyphylaxis is an acute decrease in the therapeutic response. Therapeutic index is the relative measure of the toxicity or safety of a drug, the ratio of the median toxic dose to the median effective dose. Drugs with a high therapeutic index, such as valproex, is which the therapeutic index for that drug is 50 to 125, have a higher margin of safety. That is, the therapeutic dose and the toxic dose are far apart. Drugs with a low therapeutic index, such as lithium, which is 0.5 or 0.6 to 1.2, have a low margin of safety. That is, the therapeutic dose and the toxic dose are close together. The pharmacological management process. First, we make a diagnosis and identify the target symptoms. Consider the phase of the illness, such as acute, relapse, or recurrence. Assess prior personal and family history of response to certain medications. Assess the client's motivation for and any misgivings about treatment. Identify potential interactions between the currently prescribed medications. Identify cultural implications of certain drugs. Discuss the risks and benefits of treatment. Document informed consent and the client's understanding of target symptoms, benefits, risks, and alternatives to treatment. And then monitor response and side effects. Follow-up and the PMHNP standards of care. Determine the length of treatment and perform relapse planning, and that is relating to follow-up. It is helpful and advised to use standardized clinical rating scales to establish the client's baseline and to monitor progress or decompensation over time. Screening tests will also aid in making a diagnosis and ruling out other disorders. It is important to recognize the large body of evidence-based data supporting the combined use and pharmacological and non-pharmacological treatments as offering psychiatric clients the best possibility for significant clinical improvement. Non-adherence is a common problem with all chronic illnesses, including psychiatric disorders, and should be a continuous focus of concern for the PMHNP. A Drug Enforcement Administration, or DEA, number is required for prescription of controlled substances. Controlled substances are scheduled 1 through 5. Schedule 1 controlled substances have high abuse potential. It's, according to the Purple Book, it's for research purposes only. I'm not certain why that says that, but I'm including it there. And it's not legally prescribed. Some examples of this are still listed. Marijuana is still listed because the book is definitely not updated in areas. And then of course there's heroin. I don't know if marijuana is still considered a Schedule 1, but there's heroin, marijuana, LSD, ecstasy, all that is Scheduled 1, high abuse potential and not legally prescribed. And here's Schedule 2 substances, and some of these rules I'm pretty certain are not updated, but because they're in the book, I'm just going to just name them off. And so these Schedule 2 are medicinal drugs currently in use. There's still high abuse potential for level 2 and the dependency potential. Written prescription only. I think there's a different way to do that now, but there's no telephone orders allowed. That's probably still relevant, and no refills on a prescription, and that's probably accurate as well. Schedule 2 drug examples from the book are morphine, codeine, fentanyl, methadone, hydromorphone, which is dilaudid, oxycodone, OxyContin, Percocet, hydrocodone, Vicodin, amphetamine salts, and methylphenidate. So that is Schedule 2 drugs. So that includes the Adderall, amphetamine salts, hydrocodone, opiates, codeine, fentanyl. Okay. Scheduled 3 controlled substances are medicinal drugs. There's written prescriptions are allowed. The prescription must be renewed every 6 months. There's a 5 refill limit. There's included in Schedule 3 drugs are appetite suppressants, butalbital, and testosterone. There's also buprenorphine and naloxone, and that's controlled 3 substances. Buprenorphine and naloxone are controlled 3 substances. Controlled substances scheduled 4 are the Z drugs like zolpidem, Ambien, Lunesta, also benzodiazepines, such as there's many, but Scheduled 5 controlled substances are medicinal drugs with the lowest abuse potential. They're handled in a manner similar to non-controlled drugs. Examples are buprenorphine, which is Buprenex, Robitussin with codeine, promethazine, which is Phenergan, and Lamotil. It is vital to be aware of the teratogenic nature of many psychotropic agents. It is important to discuss the risks versus the benefits of medications during pregnancy. Possible risks of psychotropic medications during pregnancy include problems with appetite, transient agitation or sedation, premature labor, drug discontinuation syndrome or withdrawal, teratogenic effects of certain psychotropics. On the reverse side, possible risks of not taking psychotropic medications during pregnancy, when obviously they're needed, is the recurrence of mental health symptoms, adverse effects of the mother-infant bonding, or on the mother-infant bonding, and poor maternal self-care. The FDA drug pregnancy labeling has changed as of 2015. Our book, or this book, however, is still talking about the pregnancy categories as with the lettering A, B, C, D, and X. So I will just discuss it, and then on the next slide we'll talk about what it is now. And I'm not sure how the test is going to handle this portion, but anyway, the FDA classifies various drugs used in pregnancy into 5 categories, or it used to. The categories were A, B, C, D, and X. Category A is considered the safest category, and X is absolutely contraindicated in pregnancy. And this used to provide a therapeutic guidance for the clinician. And I'll still go ahead and run through these. So A is the studies showed no risk. B, there's no risks in human. Category C is risk cannot be ruled out. D is there's a positive for risk, and X is absolutely contraindicated. So the new pregnancy category labeling for over-the-counter medications have not changed. As far as over-the-counter drugs, products are not affected by the new FDA pregnancy labeling. And by new, I mean that was in 2015. So let's see, pregnancy includes labor and delivery. So the new pregnancy lactation labeling rule, that's PLLR, has taken effect on June 30th of 2015. The mandate from the FDA eliminated the standard pregnancy category letters for prescription medications, A, B, C, D, and X. The new recommendations are now in the form of drug labeling that contains increased detail but also increased complexity. And the most notable change of the PLLR is that it will remove arbitrary and often misinterpreted pregnancy labeling categories for pharmaceuticals. So instead of the A, B, C, D, and X, the package inserts will now contain individualized narrative summaries for each medication that includes the risks of using a drug during pregnancy and lactation, a discussion of the data supporting that summary, and relevant information to help healthcare providers make prescribing decisions and counseling women about the use of drugs during pregnancy and lactation. So none of that was updated in the Purple Book, obviously, because I believe it's from 2012. But here it is, and again, not sure what the ANCC is going to do when it comes to test questions. Teratogenic risks of common psychiatric medications are: the benzodiazepines will have a high risk for floppy baby syndrome and cleft palate. Carbamazepine, which is Tegretol, will have a high risk for neural tube defects. Lithium, or Escalith, will have a high risk for Epstein anomaly. And divalproic sodium, or Depakote, will have a high risk for neural tube defects, so same as carbamazepine, neural tube defects, but specifically spina bifida, atrial septal defect, cleft palate, and possible long-term developmental deficits. Medications that can induce depression, I'm going to list only some of the ones that are listed because I'm just not going to remember every single one. But medications that can induce depression are beta blockers, which are the LOL drugs, steroids, interferon, which is a cancer medication, isotretinoin, Accutane, we know that's for acne, some retrovirals, benzodiazepines, and progesterone. Some medications that can induce mania are, again, I'm just going to list some of them. The more common ones, in my opinion, are steroids, Antabuse, which is disulfiram, isoniazid, which is INH for TB, antidepressants in persons with underlying bipolar disorder. And then drug screen Drug screen false positive for amphetamine can be caused by pseudoepinephrine, nasal decongestants, Wellbutrin, and fluoxetine. False positive results, drug screen results for alcohol could be Valium. If you're taking Valium, it could be false positive results for alcohol. False positive drug results for benzodiazepines can occur if the person is taking sertraline. False positive results for cocaine in a drug screen can result if the person is taking amoxicillin, most antibiotics, and NSAIDs. False positive drug results for heroin or morphine can result if the patient is taking or is on quinolones, rifampin, codeine, or even eats poppy seeds. And that's false positive for heroin or morphine. False positive drug results for methadone or PCP can be caused by over-the-counter cough medications such as NyQuil, dextromethorphan. For the medication portion, the book simply has a table 7.2, and it lists all the medication separated by category. It doesn't go into any one of them, so I will make a second video breaking down the drugs because I definitely want to know more than just what they are and what classification. And I do, but it would be a good review, I think, to make a second video for that. So I'm just going to name off the medication that are listed in the purple book, and I might even leave some out if I personally have never heard of them. But for the most part, they're all familiar to me, and I think they're common drugs. So the antipsychotics, they're divided, as we know, into typical antipsychotics, the first generation, and atypical, the second generation antipsychotics. And so I'll just list them. So the typical are Haldol or haloperidol, loxapine, thioridazine, which is Mellaril, thiothixine, which is Navain, flufenazine, which is Prolixin, Serentil, never heard of that, but it does end in zine, so probably belongs there. Triflufenazine is stelazine, chlorpromazine, which is thorazine, and perfenazine, which is trilofan. All of those are first generation typical antipsychotics. Second generation antipsychotics are clozapine, which is Clozaril, ziprasidone, which is Geodon, risperidone, which is Risperdal, quetiapine, which is Seroquel, olanzapine, which is Zyprexa, aripiprazole, which is Abilify, paliperidone, which is Invega, leoperidone, which is Fanapt, acenapine, which is Saphris, and lorazodone, which is Latuda. And yeah, that was all listed there. And then next slide will be talking about mood stabilizers. The mood stabilizers are medications used to treat mood disorders and bipolar affective disorders. And what's listed in the book is valproic acid, which is Depakine, divalproic sodium, Depakote, lithium carbonate, Escalith, lamotrigine, which is Lamictal, carbamazepine, which is Tegretol, carbamazepine ER, which is Equetro, and oxcarbazepine, which is Trileptal. Medications used to treat mood disorders, unipolar affective disorders, and depressive disorders. And we'll start with the tricyclic antidepressants. I've included the images of an EKG because these affect cardiac status, and we should definitely be monitoring EKGs if we're using these medications. But anyway, tricyclic antidepressants are clomipramine, which is anafranil, amoxapine, which is Ascendin, amitriptyline, which is Elavil, desipramine, which is norpramine, nortriptyline, which is Pamelor, doxepin, which is Sinequan. Never heard of it. Trimipramine and imipramine, which is Tofranil. Imipramine, which is Toframil. And one I hadn't heard of is timipramine, which is Sermontil. And anyway, these are all TCAs. Next, we have the SSRIs, or selective serotonin reuptake inhibitors, citalopram Celexa, fluvoxamine, which is Luvox, paroxetine Paxil. There's paroxetine mesylate, which is Paxiva, fluoxetine Prozac, sertraline Zoloft, escitalopram Lexapro. The monoamine oxidase inhibitors, the MAOIs, there's 3 specific ones listed. I'll just name them exactly as I see them. There's phenelzine, Nardil, selegiline transdermal patch, which is MSEM, and there's Parnate. The generic is hard to pronounce, but trenylcropamine, something to that effect. But Parnate is the name I'm used to, and that's the MAOIs. Just the 3 MAOIs that are listed here. There's definitely a few more that are very familiar. The SNRIs listed in the book are, and that's serotonin norepinephrine reuptake inhibitors, are venlafaxine Effexor, desvenlafaxine Prestique, and levolmilnacipran, which is Fetzima. There's also duloxetine, which is Cymbalta, and those are the only SNRIs listed. And I'll go through them again. So venlafaxine Effexor is an SNRI, desvenlafaxine, which is Prestique, which is an SNRI, duloxetine Cymbalta, SNRI, and lastly, levolmilnacipran, which is Fetzima. The 2 SARIs listed, or serotonin antagonist and reuptake inhibitors, so that's SARIs, are trazodone, which is Deseril, and nefazodone, which is Cerazone. So trazodone, Deseril, and nefazodone, which is Cerazone. Those are both serotonin antagonist and reuptake inhibitors, SARIs. The only medication under the classification of serotonin norepinephrine receptor antagonism, so SNRA, serotonin norepinephrine receptor antagonism, is mirtazapine, which is Remeron. And the photos I've included are purposeful, and if you know anything about mirtazapine, then the photos are going to make sense. And Wellbutrin is listed. Wellbutrin, which is bupropion. Wellbutrin is a DNRI, sometimes called NDRI, but it's DNRI. So dopamine norepinephrine reuptake inhibitor. And again, if you're familiar with that medication, then these photos are going to make sense. The only serotonin multimodal drug mentioned is vortioxetine. In the Purple Book, it's still called Brintellix, but it is currently called Trintellix. Listed under other agents are 2 beta blockers, propranolol, which is Inderal, and atenolol, which is Tenormin. Under stimulants, they're mixed in their categories, but it's just listed under stimulants. I'm just going to read this list. Amphetamine, dextroamphetamine, Adderall, dexmethylphenidate, Focalin, dextroamphetamine, Dexedrine, methylphenidate, Ritalin. Methylphenidate also is listed under Concerta, and lisdexamphetamine is Vyvanse. Under other agents, I'm not going to create a separate slide, but under other agents, there's guanfacine, Intuniv, clonidine, which is Catve, atomoxetine, which is Strattera. And then it says antidepressants such as desipramine, norpramine, venlafaxine, Effexor, and bupropion, Wellbutrin are also used in clinical management of ADHD, which now we know is very common, not so much like a new thing. This concludes a recap of Chapter 7, the Pharmacology chapter of the PMHNP Review and Resource Manual. And it doesn't have hardly any added information. It's just basically a recap of what's in the book. And I'm going to make a separate video going over specific medications a lot more in detail because that's just the way I like to study when it comes to the pharmacology section. So I'm not sure if it was condensed this way because it's not going to be heavy on our boards exam, or because we're expected to know, or I don't know why, but it doesn't break down these drugs any further other than listing them. But I'm definitely going to break them down in other videos. Okay, that concludes this presentation.